So, Ali, we've gone through a lot. We've talked about many of the issues related to making a diagnosis. In specific, let's talk about differential diagnosis and apply some of the things that you've discussed so beautifully, and kind of give the docs a chance to put it together and see how the pieces fit together.
Yeah. So basically, the diagnosis, or in our case, the differential diagnosis, is the culmination of all the interview questions that we've had with the patient. Taking a look at the chief complaint, the medical history, the dental history, having basically taken all that verbal information out of the patient, try to understand their pain the way they're experiencing it themselves, so that we can then use our base understanding of pulpal physiology, anatomy, and histology to make sense out of what their problem is, and then do our own clinical tests based on the extraoral and intraoral and the radiographic exam. And then, if necessary, run some other tests so that we can put all of that information together and come up with a overall diagnostic picture that explains their problem or their chief complaint, which is just the beginning, from which then we will try to create a treatment plan to move forward with treatment to alleviate it. Mm-hmm. I think the most important thing to realize at this point is that one of our goals here as endodontic diagnosticians is to have a pulpal and periapical diagnosis. And we talked about the 2009 AE terminology that was published recently and is now available. This is the terminology that we all have to learn and use clinically in the patient's chart before we start any kind of an endodontic therapy. We should have a clear pulpal diagnosis and we should have a clear apical diagnosis. So to just kind of review these very quickly, obviously on the pulpal side and the apical side, we start from a normal state where you have a normal pulp and a normal periapical area. Then pulpally, you could have inflammation, which is pulpitis. And the question at that point is, how can we decipher whether you have reversible versus irreversible pulpitis? And we talked about the differentiation factor there being the presence of either spontaneous pain or the presence of lingering pain to thermal stimulus. And those are the two main things that differentiate between reversible and irreversible pulpitis. And they're the foundation of at what point do we start to do endodontic therapy and intervention. Because reversible pulpitis can revert back to normal if you remove the cause, but irreversible pulpitis cannot revert back to normal even if you remove the cause, because it's basically gone over the hill and it's done. Irreversible pulpitis, as we mentioned, has two different types, symptomatic and asymptomatic. Symptomatic is the typical toothache that the patients come in to see us for with a chief complaint. That's a pulpitis where the patient's having spontaneous pain, lingering pain to cold, to hot, to biting forces, and so on. Those are all possible sources for irreversible pulpitis that is symptomatic. Asymptomatic irreversible pulpitis is a new term that is now used primarily to define those cases where we know, based on the amount of decay or the restoration or any of those things that is present, that by the time we're done with the decay excavation and removal, we're going to have exposure and we're going to need to do the root canal therapy at that time. Then we can assign asymptomatic to be during a pulpal exposure. You go in there to remove a carious lesion where you thought everything was going to be shallow, but you end up in the pulp and now you need to do a root canal. That gets a pulpal diagnosis of asymptomatic, irreversible pulpitis. Then you have pulpal necrosis, which is when irreversible pulpitis goes on for a while. The compensatory mechanisms of the pulp are overwhelmed and the pulp dies. The pulpal necrosis is basically the definition of a dead pulp. Then we have a case of a previously treated pulp, which is one in which you've had a previous root canal, and now you're seeing the patient, but the patient still has pain on that tooth. Usually in those cases, it's a apical problem that is present, but because of the fact that you need to define every tooth with a pulpal, assign a pulpal and an apical diagnosis to every tooth that is going to be treated endodontically, those cases get a pulpal diagnosis of previously treated. And then there is, finally, for pulpal status, you have the terminology of previously initiated therapy, which is those cases that have been started previously during an emergency visit, but now require to have endodontic therapy. So that would be your previously initiated therapy. Now, on the apical diagnosis part, as we mentioned, we start from normal, and then you start to have accumulation of trauma at the apex, in the periodontal ligaments, and into the periapical tissues, and that results into apical periodontitis. That could be either symptomatic or asymptomatic. Symptomatic apical periodontitis is usually associated with a tooth that is exquisitely sensitive to percussion, or not necessarily exquisitely, it's sensitive to percussion, basically. These patients obviously will complain of pain to chewing and to pain and to tapping on the tooth and so on. But they could also have a patient that have apical periodontitis where it's an asymptomatic type. And those are cases that you basically have your typical granuloma at the end of the root. You have a lesion that you see radiographically, but the patient is otherwise asymptomatic. It could even be negative to percussion. It could be positive to percussion, it could be negative to percussion, but the patient doesn't have any complaints associated with that tooth themselves.
Can occlusion cause that?
So occlusion would cause symptomatic apical periodontitis, which would then have to be adjusted because it's a reversible condition. And the reason why is because the source of the problem is just the periodontal ligaments at the apex. Right. There's no pulpal problem associated with that. And then the pulp will revert back, and so will the periapical areas. So that would be considered a symptomatic apical periodontitis with reversible pulpitis. Right. So that would be the definition of a tooth in pulpal in occlusal trauma. Then apical periodontitis will lead into apical abscess, which could have either an acute or a chronic type. And the difference between the acute abscess and the chronic abscess has to do with whether there is drainage or not and whether there are symptoms or not. The acute abscess is one which is your typical abscess. You have soft tissue swelling, you have fluctuants, and you have pus, that is the presence of pus where it's spreading across the fascial planes. The chronic abscess is one in which there is a path for drainage, and that would be a sinus tract. And the difference between a sinus tract and a fistula, Dennis, is?
No, I'm not answering that. You're answering that.
This is a pathological terminology. A lot of people call these things fistulas, but at least to be the word police here, there's a difference between a fistula and a sinus tract. And a fistula is a path or a communication between two anatomical entities. However, a sinus tract is a path that communicates a pathological entity or a cavity to an anatomical one. So in the case of a oroantral fistula, you have a fistula because it connects the oral cavity to the sinus cavity. But in the case of a sinus tract where you have an abscess that is draining, that is the pathological entity that is being drained into an anatomical cavity, such as the oral cavity. So use the word sinus tracts. Do not use fistula. It is the incorrect term. And finally, at the end, you have condensing osteitis, which is a terminology that is used to define a reactionary bone to inflammation either in the pulp or around the periapex that is present oftentimes, but is not necessarily there all the time.
You know, Ali, what I kind of like about the concept of having two distinct but comparable diagnoses, one pulpal, one periapical, is it is a second check almost on the reality that these things should make sense. One should support the other. And you wouldn't typically, you would know immediately that you would be wrong if you were to write down,
vital pulp, reversible pulpitis, and apical abscess at the same time.
Exactly. Yeah. So it's just a almost second check on what your diagnosis is.
You're absolutely right. I think it's a system of checks and balances that
Yeah.
they've put together, which is why the importance of having a pulpal diagnosis and apical diagnosis together hand in hand will give you the right answer. So let's take a look at some of the typical cases that we run into in practice on a daily basis. Nothing that is a really crazy zebra or anything like that, but the cases that you see every day in practice, and how can you use the 7 steps to arrive at a systematic approach to look at these things very quickly so you can have a diagnosis. So the first patient here is we have a lateral incisor tooth, and this patient presents with a chief complaint of a bubble that pops from time to time in the gum. They point to the area of the infection, and this patient unfortunately has a history of myocardial infarction. And their dental history shows an asymptomatic area. That is, by that I mean no sense of major pain that happens spontaneously or anything like that. They know historically a history of treatment performed, that they've had a root canal done in this area back in the 1960s when they were very young, and that this sinus tract has been taking place, coming on and on for a while. Now, the extraoral exam doesn't show anything. The intraoral exam shows a sinus tract opposing the maxillary lateral incisor. The fact that you have no probing is important to know, because it kind of tells you that the problem is limited to the apex and that the attachment is not lost as a result of it. And the tooth is a little bit different to percussion, but not particularly sensitive to percussion during the testing. It is also a little bit sensitive to palpation, because you can see the sinus tract, and the area of the opening of the sinus tract is usually slightly inflamed and rolled. The sinus tracts usually, Dennis, are lined by either granulation tissue, or if they've been present for a long time, they could be lined by epithelium, which kind of makes them a little bit more persistent. And in this case, obviously the 6th step, which is our radiographic analysis, shows that there is a silver point present, and it's been done in the form of a root canal, and that there is an apical radiolucency of a fairly large size. It is, it's kind of round. It's not very, the borders are not very clearly defined, but you can see it as pretty clearly on the X-ray, and that you can see even from the radiograph right around the silver point that there is a pore seal around this. And that obviously, having a little bit of an endodontic understanding, the silver points were done quite frequently back then. They were using zinc oxide eugenol-based sealers, and these sealers do resorb over time, and that's the problem with them. So that's why silver points always failed in the long run, because the zinc oxide, the ZOE-based sealers that were used were just washing out from inside the tooth, and they were exposing the silver that would corrode over time. And then they would also provide areas of leakage, and that's what caused the problem. In this case, we didn't obviously need to do any additional testing, and this was very clear that our pulpal diagnosis was a previously treated root canal, and our periapical diagnosis was a chronic apical abscess. Now, it's a chronic apical abscess because there's a sinus tract present. If there were symptoms present, and if it was swelling and the sinus tract was closed, then we would have an acute apical abscess. So for the next patient here, we have a patient with a chief complaint of pain to chewing. There is no significant medical history here. And then we have a symptomatic tooth that has had a filling a couple of years ago, and has been in kind of pain over the past 6 months, coming and going in this area. And there is a little bit of swelling now involved with this submandibular space of this tooth. And, it's on the extraoral examination. On the intraoral examination, you can also see a little bit of swelling on the buccal, as well as the lingual aspect of the tooth. And the tooth is positive to palpation. The periodontal probing around the tooth, however, is normal. Usually cases like this where there's an infection around it, you're going to get a little bit of bleeding upon probing, but the key is that the attachment is there. And that's an important thing, because the infection doesn't just get, localized to the apical area. It does move around a little bit. It just doesn't. So the teeth around and the gingival attachment will be slightly inflamed, usually in cases that have massive apical infections too, except that you don't have a complete loss of attachment. It's important to consider that. And the tooth obviously tests positive to percussion and to palpation, but is negative to our pulp vitality testing. In this particular case, we used the cold, in which it was completely negative. You could use the EPT here as well, but usually, when you have a picture that is complete with this test, you don't need to do multiple redundant tests. We have to have the understanding of the redundancy of the tests and apply them when one test doesn't appear to be confirming something, or that it is we feel that it's unreliable. For example, if the tooth behind it didn't also test vital to the cold test, then I probably would want to take the EPT test and retest with the EPT to make sure if I can get a response from them. Then obviously from the radiographic analysis, you could see the apical radiolucency and the deep restoration. You can see some calcification also in the pulp of this tooth. So here we don't need to do any of the additional tests here because our diagnosis is fairly clear that we're dealing with a pulpal diagnosis of necrosis due to no response to our vitality tests, and also a periapical or apical diagnosis of acute apical abscess. And it's an acute apical abscess because of the fact that you're having swelling present, you have submandibular space that has been involved here, and the patient is symptomatic and in pain.
Question related to just the degenerative process. Do you find that in a molar tooth that all the roots are affected somewhat equally by the process of degeneration, or could you have a lesion, as for instance, could you have a lesion on the mesial root and the tooth still be responsive to cold?
So
because it's still
yes.
vital in the distal root.
Yeah, this actually would be one of the zebras usually during our testing as well. What is one that doesn't occur that commonly. It's been described in the literature. I can tell you that I probably have seen this maybe once in my career, once or twice in my career, in which case it's usually associated with dystrophic calcification, where you have multi-rooted teeth. For example, the same tooth that you're seeing here, if the chamber calcifies in such way that it could actually section off the distal root from the mesial roots, and the calcification is so complete and the reparative dentin that is in there is so well sealing that bacteria from one side could not get to the other side, you could theoretically end up with a situation in which a case like this, where you have deep decay in the distal, could cause devitalization of the distal root and have mesial roots that are vital. But obviously you would not be seeing a lesion around the mesial roots, right? So you would have that present.
Right.
But this, again, is very rare, and that's why we normally don't talk about it, because it just gives a lot of times, it gives people, one more thing to be confused about.
Okay.
I think the fact that it is so rare that I have probably seen it only once or twice in my career, it just means that we probably should assume that once a tooth is responsive, and a multi-rooted tooth is responsive, especially if it's responsive completely within normal limits, that it is vital. We shouldn't assume that one of the roots has gone dead and the other ones are vital and we're getting a false positive. And it's just for practical purposes, I think it makes sense to act and to treat these teeth that way, because it just saves us from, cavalierly going in there and doing a treatment that may later on not, become clear that it's not necessary. So let's take a look at another case here. This patient had no chief complaint. It was basically an accidental finding on the radiograph, the lesion that you can see here on the distal area. The patient has a history of Sjogren syndrome and has poor oral hygiene, has basically had no treatment and seen the dentist in a couple of years. Their extraoral exam is normal, and their intraoral exam is showing a positive sensation to thermal testing without any lingering on tooth number 30. And the tooth is negative to percussion and palpation, and it just feels a little bit different to the tooth sleuth. Basically, the radiographic examination shows a distal decay on the tooth, but no periapical radiolucency or anything like that. So, you might see some people could interpret a little bit of thickening of the periodontal ligament on the distal root, but this is basically, again, an angulation issue the periapex and the bone looks very normal. I guess you could make you could say that there is a radiolucency on step 6, and it's not quite within normal limits. Obviously, there's a radiolucency in the coronal part of the tooth, but no additional tests are needed here. And this is one of those cases which would be considered asymptomatic irreversible pulpitis. And the reason for that is because while the tooth is really not testing symptomatically, by the time you remove all that carious lesion from the tooth, you will end up getting a pulpal exposure. And again, it goes back to explain that the diagnostic criteria that we have, pulpally and periapically, are clinical and they're not histological. So we use the term asymptomatic irreversible pulpitis in cases in which we're doing pre-prosthetic work or anticipating the high risk of infection that is very likely going to happen, and therefore we need the root canal therapy to be done. So we assign asymptomatic irreversible pulpitis to the pulp of such teeth. And in this case, the periapical area is obviously normal. So also to talk about that last patient, I just want to kind of mention that, when you look at the medical history, for example, somebody who has Sjogren's syndrome, Sjogren's disease, you realize that these people are going to have dry mouth. So in terms of our responsibility to educate these patients about the importance of proper oral hygiene, putting them into a routine of being seen more more frequently will help them in terms of reducing these types of lesions and the carious lesions that could happen very rapidly in people with xerostomia due to whether it's medication causing xerostomia or diseases, autoimmune diseases such as Sjogren's or any of the other ones. But let's take a look at the next case here. This case is a tooth in which you have a pain to chewing as a chief complaint. There is no significant medical history. And the dental history is showing a recent filling in teeth 30 and 31, which hurts only when you're biting in a specific way. When you bite, the patient is biting in a specific way. And the extraoral exam is normal, and the intraoral exam is positive to thermal testing without any lingering on the tooth number 31 and tooth number 30 as well. But the tooth is negative to percussion on palpation, but only tooth number 31, you end up getting a response to the biting test or the tooth sleuth. The radiograph looks normal. There's no real pathology going on there. There are shallow restorations in place. And at this point, you don't require to have a lot of other tests because this is a very classic picture of patients that we see following recent restoration where they claim to have sensitivity. This patient may have not had any sensitivity prior to the placement of these restorations, and these could have been replacements of old amalgams, or they could have been new restorations and so on. But the question is, why is it that a tooth that otherwise has a vital pulp is responding to the tooth sleuth only on the second molar? And that is really a question about the diagnosis. Well, first and foremost, you have to understand that these cases, the pulpal and the periapical diagnosis would be considered reversible pulpitis, and the periapical diagnosis would be normal because there's no lingering reaction with the pulp in this tooth. You're basically having a problem here that is dentinal sensitivity. Right? It comes from the movement fluid in the dental tubules as a result of cuspal deflection. Now, the cuspal deflection could be due to a crack in the tooth, or it could be due to this restoration that was placed not having an adequate bond or adequate seal. So if a crack was seen at the time of the placement of the restoration, then it could be attributed to the potential crack. But many times, these restorations, especially with these bonded restorations now, where we are etching the dentin, we're exposing the dental tubules, we actually are increasing the dental permeability. If at the time of placement you are not fully placing your bond and occluding the dental tubules, then if you have any areas where you're not getting proper bonding with the restoration to the dentin, you end up getting that kind of a cushioning effect where sometimes if they're biting on the composite, they're creating fluid movement in the dental tubules that will create that little zinging sensation when they're biting on the tooth. And when that goes on for a while, that could become that could create sensitivity in the pulp of the tooth due through various kind of neuroinflammatory steps where the chronic stimulation of these nerves, the A delta fibers as well as the C fibers, releases inflammatory mediators inside the pulp that actually makes the pulp increasingly more inflamed. And that's the mechanism for that. there could be dental sensitivity. So, in terms of the treatment planning for cases like this, which is not the subject of this conversation, but this, I'm sure a lot of people are interested in that because I'm sure everybody sees cases like this. Ideally, if you did not see a crack at the time of the placement of the composite, it would be best to replace the composite and place either a sedative material such as a zinc oxide eugenol based on IRM or something like that in there, or reseal the material in a better way so you don't end up having exposed dentin. That's a critical thing. If you saw a tiny crack underneath there, then the next step would be to place a casting, a crown, which will 360 degrees try to protect the cusps and prevent cuspal deflection. So in the next tooth, we're going to talk about another situation that you run into nowadays routinely, as it seems to me like almost the majority of children or teenagers are going through orthodontic therapy. There is a lot more incidence of external root resorptions and various kinds of resorptions. And we can't obviously blame that on orthodontics. There's trauma, and there's also some idiopathic causes for external and internal root resorption. But these things are always associated with some kind of a traumatic event, and that could be, including trauma, direct trauma to the face, to the teeth, or even movement of the teeth through orthodontic therapy. This patient presents, for example, with no chief complaint. This is the medical history is not significant. It's a fairly young patient. You have the dental history is only significant for the history of orthodontics. Our extraoral exam is normal, and our intraoral exam, everything is basically within normal limits. This is the part where the radiograph is the only thing that is dictating the diagnosis here, where you see this diffuse radiolucency. And as I said, traditionally we've been using the slob rule, take a couple of different angles to see if this is external or internal, where does it lie on the plane of the X-ray. But nowadays, this requires that seventh test, the other test, which would be the CBCT. And the CBCT will show us the extent of the lesion, whether it's buccal, lingual, is it repairable, is it not? And then the decision to be made here is one that has to do with the accessibility of the lesion, the extent of the lesion, and the rate of growth of the lesion. Again, these are things that are related to the treatment planning portion of a case. We're only interested in diagnosis here right now, which means that our pulpal diagnosis for this tooth is normal and the apical diagnosis is normal. As surprisingly, these are the new diagnostic terminology you should be aware of, and these are the new AAE standards. However, the overall diagnosis of this case would be external root resorption as a condition, and then the treatment that follows would be based on that. And now we get back to the case that we started with here, the first radiograph, which was a patient that if we were to judge this case based on the X-ray alone, we would first be drawing our attention to the first molar, where there's a previous root canal and a large lesion. But when we go through the 7 steps, we find out that the patient's chief complaint is pain to the cold. And while their medical history is insignificant for anything, their dental history is significant for having had a root canal on this tooth, tooth number 30 in that area over 12 years ago. And then, we do our extraoral exam, which is non-contributory, and our intraoral exam shows the area being completely negative to percussion and palpation tests. However, our cold test is the thing that allows us to duplicate the chief complaint, which, as we mentioned, is the goal of our diagnostic processes. So we put the cold on tooth number 31, which is the second molar, and immediately we can trigger the chief complaint. And that tells us that that is the source. And oftentimes you have the patient, as they raise their hand, they say, that's it, that's the one. They can tell because it totally reminds them of their chief complaint and the times when they've been having the pain themselves at home. And in this case, the radiograph shows the radiolucency around the other tooth, but not anything around the apex, at least, of the second molar. But you can see on the second molar that there is a little bit of a radiolucency underneath that old composite that ends up being actually decay underneath there. No additional tests are needed here, and our diagnosis for this tooth, number 31, is clearly a pulpal diagnosis of symptomatic irreversible pulpitis. This patient had a lot of pain, but the apical diagnosis is normal. These are the ones where you really need to do your pulpal testing because your percussion test will tell you nothing. So that's very important to be aware of that. And the diagnosis for the other tooth, which is number 30, Pulpally, it would be a previously treated root canal, and apically, it would be an asymptomatic apical periodontitis. And the reason why is because you basically have a granuloma there that is asymptomatic. There is a lesion there. There's probably something going on. That tooth does need treatment. It just doesn't need it right now because that's not the patient's chief complaint. So that's basically it. Some of these cases are important to keep in mind, the basic everyday cases that we run into, and that's what we wanted to just kind of review with you.
So as we finish up, what happens when you just cannot make the diagnosis? Does that happen? I mean, does it,
Yes.
once in a while, you have to look the patient in the face and say, hey, listen.
Unfortunately, Dennis, you go through the 7 steps. You could put an 8 or a 9 or a 10 step in there, and sometimes you're just not going to know. And that's something that goes back to the art of the communication. How do you communicate that with a patient that has come to you looking at you as a figure of authority? You're the doctor. How can you, not know? What do you mean you can't tell me what's going on? What I would like to really emphasize here is that when you do not know what to do, the key is not to do anything, because that is the most conservative approach. And my line to my patients is that, Mrs. Jones, I know you're in a lot of pain, and I know, you think if we do this root canal for you, it will help you get rid of the pain because you're convinced that it's your tooth that's causing you pain. But what's worse than having a root canal is having a root canal and still having the same pain. So the key here is making sure that we've diagnosed the cases to a point of confidence in which we feel adequately prepared to drill into the tooth, because it's not just the root canal. The patient's buying into the root canal, the core, and the crown that ensues. There's a lot of investment. And communicating this to the patients in a way where they understand that you're on their side and you're trying to protect them helps them be more patient with their pain. Because one thing that is for sure about all odontogenic pains, that they have a beginning, and thankfully there is an end. So during the time where the pulp is dying, that is the time where you have very
have a good
kind
chance.
of a, well, yeah, while the pulp is dying, the pain is diffused. It's all over the place. That's the time where it's most difficult to diagnose a case.
Yeah.
And especially in cases where you have multiple restorations, lots of crown and bridge, where you suspect a couple of different teeth that could be potentially the source, the question becomes, how do we, what do we do? Do we just go eeny, meeny, miny, mo and choose one? Or do we do the responsible thing, explain to the patient the limitations of our diagnostic tests, and explain to them that if they wait long enough, the pain almost always localizes. During the acute, dental pain doesn't last forever. It's very bad, but it's very bad for a period of time until the pulp dies. As soon as the pulp dies, then you have a period of relief. And that becomes your kind of the eye of the hurricane, if you will. Well, things are suddenly calm, and you have some time that passes by before the infection reaches the apex. And then as soon as the inflammation reaches the periapical area, then percussion tests will tell not only you, but the patient will already know. They come back and say, now I know which one it is. It is, the front part of the bridge or the back part of the bridge or this tooth or that tooth. They will point to it directly. And it goes back to our pulpal biology to kind of wrap the whole thing up in a circle. The reason why pulp biology is important because it allows you to understand that, the reason why you can't tell where the pain is coming from is because you have no proprioceptive nerve fibers in the dental pulp, or you don't have enough of them so that the patient can themselves be the best source of information for where the pain is coming from. You'd have to wait for the symptoms to mature so that the inflammation reaches the apex. And at that point, then they will have the information. They will have the proprioceptive fibers from the PDL that will tell them where the pain is. In some of those cases, that could go on very quickly. What I can do sometimes for patients like that, you can give them actually a block anesthesia with Marcaine. And if you're between 2-3 teeth, you can give them a block anesthesia. That keeps them comfortable for a period of time. And we've actually had to nurse some patients that are just so complicated to determine for maybe a couple of days in a row with just Marcaine until we've had, things have localized. They've come in every day, so I could have in the morning tested it out. And if I couldn't test, I still didn't have the answer, give them a shot of Marcaine. They'd be numb for a good, 8 hours, 8 to 12 hours, if you will. And they won't have pain at least, so they would be functional. And you'll just wait until the process of necrosis takes place and the inflammation reaches the end of the root. And then they come back to say, That's the tooth. Let's do it.
Okay.
And I tell you, maybe 80, 90% of the time, I've been right in what I thought was probably the case, but I was wrong a good 10, 20% of the time in those cases too. So the question becomes, and part of that has to do with communication,
Yeah.
telling the patient these are the options. I'm 80% sure. I wouldn't, in my own tooth,
Yeah.
get in there and do the root canal. But, you're an adult. You can make a decision. Some patients are saying, well, I can't go home like this.
Yeah.
Say, well, if you understand the full consequences, that I could be doing the wrong tooth. And you will end up needing not only one root canal post and a crown, but 2 root canals and a crown. It's going to cost you an extra, few grand. Are you willing to take that chance? Oftentimes that is enough to convince them that, okay, maybe I could sleep on it for a couple of days. Okay. So Dennis, that kind of wraps up some of the differential diagnosis. Let's come back here and review everything that we've talked about during a conclusion portion of this course and see where we are at after going through 7 steps and having come back to the beginning here.
Yeah, we did really come back to the beginning.
Sure have. Okay, we'll see you in the next lesson.